Good morning, everyone. Today, I have been given the task of presenting about screening and prevention of lung cancer. So, we will briefly talk about some introductory slides about lung cancer prevention and whom to screen, when, how, why to screen, and how to evaluate these patients post screening. How should we confirm the lung cancer and some adverse events of lung cancer screening. So the most important risk factor for lung cancer is cigarette smoking. So to prevent, we should advise the patients to quit smoking and avoid secondhand smoking and take some precautions to reduce the exposure to harmful chemicals at workplace. So the prevention can be primary, secondary, or tertiary. Primary prevention aims at preventing the cancer to occur. Secondary prevention is basically early diagnosis and treatment. It can be done by chest X-ray, MRI, CT scan, or sputum cytology. And tertiary prevention is basically palliative care. So currently we will be focusing mostly on the cancer screening, which is basically the process by which a large number of people within the population undergo some tests that are designed to find a occult tumor. So there are some guidelines to screen. So the USA Preventive Services Task Force basically recommends, and it is a grade B recommendation for annual screening for lung cancer with low dose CT scan in adults in between 50 to 80 years who have a 20 peak years or more of smoking history and currently smoke or have quit within the last 15 years. The point to be noted is they also have recommended the screening should be discontinued in a person who have not smoked for last 15 years or have developed a healthcare problem that will substantially limit the life expectancy or willingness to have curative intent treatment. So there are other recommendations from the NCCN and American Cancer Society. Basically, they are the same, except for the NCCN, which states that the annual screening with low-dose CT scan with patients of at least 50 years of age and have at least 20 peak year smoking history. The difference is mainly there is no upper age limit for the screening in the NCCN, contrary to the other recommendations like American Cancer Society or the USA recommendation. And the peak years they have recommended is basically 20 peak years. So there is a online site which we can go and check what is the risk factor for the lung cancer. It is shouldiScreen.com. And there are tests which we can employ to diagnose the lung cancer for screening purpose. This include physical examination, chest X-ray, CT scan, and pulmonary function test. So to screen, the recommended are basically low dose CT scan, that is up to annual screening. Chest X-ray and sputum cytology has been tested and has not been beneficial so far. The most important point in screening is the candidates should have a shared decision making before starting any screening. And the screening is not only a low dose CT scan, it is a program. So it should involve the multidisciplinary team, including the radiology, thoracic surgery, oncologist, and others. So briefly about the low dose CT scan. So it differs from the conventional CT scan by the radiation dose it has. The radiation dose is typically less than 3 millisievert in small patients, and it is typically less than 5 millisievert in large patients. And the slide width should be less than 1 mm to detect the small nodules, and it should be acquired in a single breath hold that is less than 10 seconds, and it should be acquired with maximum inspiration. The CT scan detector should be more than 16. So why to screen? Because we can decrease the lung cancer mortality. We can improve the quality of life of patients by reducing the disease-related morbidity, mortality, and improving the lifestyles. And we can also detect some other significant diseases which we would have missed if we had not done the CT scan, like coronary artery disease, thyroid nodule, renal cell cancer. And not to forget, there are some risks of screening, like detecting a small aggressive tumor, the course of which is similar whether we treat or not, and discovering some indolent nodules which will be same whether you treat or not. It will also hamper the quality of life because it will increase the anxiety and it will increase the false negative and false positive values. There is a definitive radiation exposure, though it is low. There is a cost involved, and there are incidental lesions which we are not sure. So after a screening is done with the low dose CT scan, the CT scan is looked to have any lung nodule. If there is no lung nodule, the population or the candidate will undergo the low dose CT scan annually. If there is a lung nodule, there are certain criteria in the lung rats and the NCCN which guide us how to go further. A nodule is basically defined when it is up to 3 centimeter. A solid nodule is a basically homogeneous soft tissue attenuation, and a ground glass nodule has a basically hazy increased attenuation. And the lung nodule should be evaluated in the lung window, not the soft tissue windows. And there are a certain size criteria, like more than 15 mm a solid nodule should be investigated further with PET CT or contrast CT. And if the suspicion is high, we should go ahead with the biopsy and treat accordingly. And if the nodule is less than 6 mm, we should continue the patient with annual screening. And if the nodule size is in between 6 to 15 mm, there are certain guidelines based on the suspicion. Similarly, if the nodule is partly solid and non-solid, there are certain guidelines. So to confirm the carcinoma lung, we should have a biopsy, and pathology is considered the king in oncology, as we know all. So confirmation definitely requires a biopsy or excision of the lung nodule. So there, as I've already said, there are advanced events of screening like false positive values, which will ultimately lead to the unnecessary tests, which are some of which are basically invasive. It may lead to over diagnosis, and there is a radiation exposure, and there are incidental findings, and there may be anxiety in the candidate. So these are basically some numbers. False positive value in the National Lung Cancer Screening Trial was 26.3 at the baseline, and it decreased to 19.8% at the it was 19.8 in the national trial. And over diagnosis was approximately 6%, and RT induced cancer was in between 20 to 40% per 100,000 person. So there are several incidental findings, one of which is other cancers like kidney cancer, thyroid cancer, liver cancer. The incidence was 0.4% in the NLST trial. So there was a updated analysis of the NLST trial in which the median follow-up there was 12.3 years. And there was no statistically significant difference in the low dose CT arm versus chest X-ray arm in detecting the non-small cell lung cancers. Though the numerically it was higher, there was no statistical difference. And if we can see the overall mortality, it was also not statistically significant. It was 196.6 and 200.7. So the extended analysis of the NLC trial, the difference in the proportion of the people dying from the lung cancer, it was 42.9 versus 46.2. In the chest X-ray versus the LDCT arm was 3.3 per 1,000, which translates translates into number needed to screen for preventing one lung cancer death was 303. And as I said earlier, the overall mortality benefit was not significant. One demerit was the chest X-ray was not a standard control arm, and we don't have any information post-trial screening. That is, the patients who were in the chest X-ray arm, some might have undergone a LDCT screening. The data is still not available, so we cannot conclude concretely based on this trial. Though it is the largest randomized trial till date on the lung cancer screening. Now, there is another trial, Nelson trial. They have done LDCT at baseline, then after 2 and 5.5 years, they've compared the LDCT to the no screening. And they have taken patients 50 to 74 years old who have more than 50 cigarettes a day for more than 25 years or more than 10 cigarettes a day for more than 30 years and have quit smoking less than 10 years ago. With a median follow of 10 years, they found that the lung cancer mortality was significant in the screening arm, and it was not significant in the overall mortality case. The lung cancer death was 2.43 in the LDCT arm, and it was 3.17 in the no screening arm. So there are some drawbacks of the Nelson trial also. We are not sure whether the patient has died of the cancer, lung cancer, or some other cause, because when a patient dies at home, we are not sure whether he will die of MI, he will die of some other lung cause. So it might have, so the appropriate objective for a screening trial is basically mortality rate, not a survival or other endpoints. So when we look at the overall mortality rate, it was almost similar, 13.93 versus 13.76 at 10 years. So coming to the lung cancer in India, the incidence is 5.5%. So the number comes to around 70,000, considering the population of 130 crores. So when telling a patient that whether he or she should undergo lung screening or not, we should always remember there are some harms of screening and there are some benefits of screening. Till date, there is no concrete evidence that we should counsel the patients to undergo screening only. But there are guidelines which recommend, and since we don't have any data from the developing countries, so we should counsel accordingly the patients. So as I said, there is no screening guideline in India. So we have the issues of availability of low dose CT scan, availability of the cost, and the person should be only trained in reporting the CT scan. So take-home message is basically screening may be considered in India in patients who are heavy smokers, elderly patients, but there should be always a shared decision making. Thank you. Any question, anyone? Any questions? Okay then. So one thing we should remember is basically the data still we don't have for lung cancer screening in India. We should counsel the patient accordingly. There are benefits of lung screening, but there are associated harms also, which include basically the invasive procedure, false positive rate, complication, even death. Though the death rate in the trials were lower of the order 0.017%, but still there are there. And countries like India, we have limitation of resources. So it is a Herculean task to do a lung cancer screening. Thank you.